Central venous therapy. Central venous therapy may be ordered when a patient needs infusion of a large volume of fluid, requires multiple infusions, requires long-term infusion therapy, needs infusion of irritating medication such as potassium, needs infusion of fluids of high osmolarity such as TPN. Benefits of central venous therapy include access to the central veins, rapid infusion of medications or large amounts of fluids, measure central venous pressure or CVP, reduce risk of vein irritation from infusing irritating substances. Risk of central venous therapy include pneumothorax, sepsis, thrombus formation, perforation of vessels or organs, requires more time, it's more costly, risk of air embolism, and has a greater risk of infection than peripheral access. Central vein sites include subclavian, internal jugular, the femoral, which is not recommended unless used in an emergent case. It is very important that placement must be verified before use. Central vein catheter. The catheter is inserted with its tip in one of two places. 1. The superior vena cava, if accessed through the subclavian, internal or external jugular, or the basilic, and 2. The inferior vena cava, if accessed through the femoral vein. Types of central venous access devices: non-tunneled catheters, which is for short-term use; tunneled catheters, which are for long-term use, such as with cancer patients, AIDS, and patients with antibiotic therapy, long-term that is, chemotherapy, TPN. Examples would be Hickman, Broviac, or Gershon, which requires surgical insertion. PICC line, also known as long arm or long line catheter, is useful when no reliable routes for short-term IV therapy are available. Indications include administration of IV antibiotics for an extended period of time, infusion of parenteral nutrition, chemotherapy, continuous narcotic infusions, blood components, or long-term rehydration. Implanted ports are long-term use. The central line insertion checklist should always be completed, even in an emergency situation. Remember, we try to avoid inserting catheters into a femoral vein, but if needed in an emergency situation, we must still verify placement of the line. It should be verified either by drawing an ABG from the femoral line and an ABG from a separate arterial site to verify that the femoral line is placed in the venous system. Alternative methods that may be utilized for verifying placement are bedside ultrasound and Doppler, or transducing catheter to measure placement and looking for waveform, or connecting catheter to a vertical sterile tubing and looking at the height of the blood column. The central line insertion checklist must be filled out and faxed to the Infection Prevention and Control Department at 775-9381. Changing central line dressings, site care per policy, should be changed at a minimum of every 7 days or PRN with the biopatch, every 3 days with biopatch or PRN soiled, loose, or wet. Use CVC dressing kit and biopatch. Do not use biopatch on infants less than 1,000 grams or less than 2 weeks or less than 26 weeks of life, or with a history of an allergic or sensitive to reaction to chlorhexidine, according to Vascular Policy, Patient Care 42.5. With changing central line dressings, we should assess by gathering pertinent data, allergies to tape, iodine, or components of fluids being infused, bleeding tendencies, client's ability to understand instructions. As far as planning, you want to review the chart for previous care or complications. And equipment, make sure that you have a central line dressing kit and any of the other supplies that you may need. When performing the central line dressing change, you want to implement, prior to performing the procedure, introducing yourself. Make sure that you verify the patient using the two patient identifiers, which are the patient's name and date of birth. Make sure that the patient is actually verbalizing their name and date of birth. Explain the procedure and why it is necessary. Provide client privacy, position the patient, and assist the patient to a comfortable position, either sitting or lying. Always perform hand hygiene and observe other appropriate infection control measures. When performing central line dressing changes, you always want to make sure that you prepare the patient. Apply the mask and have the patient apply their mask, or ask them to turn away. Prepare the equipment by establishing a sterile field and place the sterile supplies. Next, when performing the central line dressing change, you want to remove the old dressing. So apply clean gloves, pull both sides of dressing away from insertion site, stretching it to lift it off the skin while holding the catheter in one hand. Inspect the skin for signs of irritation or infection, drainage, redness, swelling, warmth, those types of things. Remove, discard gloves and dressing. Perform hand hygiene. Next, when performing the central line dressing change, you want to make sure that you cleanse the site. So apply the sterile gloves, clean the catheter insertion site with chlorhexidine swab in back and forth motion for a minimum of 30 minutes. Let the site dry completely. That is very important. If possible, use one hand to lift the catheter so that you can clean underneath it. When performing the central line dressing change and applying the new dressing, you want to apply the BioPatch, the antimicrobial dressing, to the catheter exit site. Remember, blue side goes up. Then apply the new transparent dressing over the exposed catheter. Remove and discard the gloves. Perform hand hygiene. Label the dressing with date, time, and your initials. When documenting central line dressing changes, you want to make sure that you document all relevant information: appearance of the catheter insertion site, presence of drainage, type of dressing applied, patient complaints or concerns, patency of tubing, and any education that was given.